The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to our Hospice Lunch and Learn. Today is Wednesday, April 10th, and my name is Erin Musamichi, and I will be your presenter today. We're going to get started in just about 1 minute. I will give about another minute for others to join the webinar. If you'll just give me a show of hands if you can hear me and see the captions loading at the bottom of your screen. Wonderful. Thank you very much. Thank you. Thank you. And just a few housekeeping items. Before we get started, I have turned off the question box for now. As we move through the presentation, I will keep that question box off, and at the end of the presentation, I will turn it back on, and we will have time for a short Q&A. This is intended to be just a short lunch and learn for just one topic, and we're going to talk about Hospice General Inpatient Care today. And I do have the chat box open. Please note that in the chat box, I have entered the survey, and if you would please just take the time to complete that survey. It's a short survey. This is how we know, to improve our education. If you take the time to do that survey, we can improve and take suggestions on how we can do better for you. We are here to support you. So again, just take a few moments to fill that survey out at the end of the presentation, and we appreciate that. All right, so without further ado, let's go ahead and get started. Again, this is our Hospice Lunch and Learn series, and today we're going to be talking about Hospice General Inpatient Care. And if you will just note that, and there's that chat, that survey in the chat box. I just hit the send button there. And if you'll take note, I did go ahead and load the PDF of the slides into the handout section of your GoToWebinar toolbar. And we will go ahead and jump right in. Here is our disclaimer. National Government Services is bringing you the most current and up-to-date information at the time that the material was developed, and all your current Medicare regulations can be found on the CMS website, which is hyperlinked here for you on the slide. All right, and there is to be no recording of our educational events, and as you can see here, this applies to our webinars, teleconferences, live events, and any other educational events that we offer. Our objective today is to define the hospice general inpatient level of care and highlight clinical documentation required by hospice clinicians to support them. My name again is Erin Musamichi. I am one of the clinical provider outreach and education consultants here on the home health and hospice team. And we are going to touch on the hospice level of care revenue codes very briefly and jump right into general inpatient care and the documentation to support that. And we'll go over the references and resources and have a little time for Q&A. All right, so I am not a billing subject matter expert. However, I think it's important for clinicians that are providing care and documenting in the medical record to have a basic understanding of how these levels of care are billed. So with that said, I'm going to provide a very high-level overview of the revenue codes that they represent from a claims perspective. There are 4 levels of care that can be billed for hospice, and often clinicians are not aware of the billing aspect of claims. But today we're going to go over some high-level billing in an effort to provide a better understanding of how clinical documentation plays a vital role in how the general inpatient level of care is billed by the hospice agency. When an agency submits a claim to Medicare, they enter codes into the system to tell a story of what services they are requesting payment for. And the codes that they enter are subject to units of service performed. So if we look at RHC, or routine home care, this is billed using revenue code 0651, and 1 unit is billed for each day that routine home care is provided. However, as you can see from the table on the slide, continuous home care, or CHC as we like to call it for short, is billed with revenue code 0652, and every 1 unit is equal to 15 minutes of service, meaning if the hospice provided 1 hour of service, they would bill 4 units. There are other coverage and billing requirements for billing continuous home care, but this is just an easy example of how to bill units for 15 increments of service. 15-minute increments of service, I apologize. Inpatient respite care, or IRC for short, and general inpatient care, GIP, are also billed with a revenue code as shown in the table here on the slide to indicate the service and are billed with 1 unit for each day the service is rendered. And whenever the different hospice level of cares are delivered, they are placed on the claim and there is a revenue code and a unit that goes with each one. And clinicians should really be mindful that they're always documenting to reflect that specific level of care that they're providing. And this is another reason why we should always try to avoid that copy and paste method of documentation to prevent easily avoidable errors as well as denials. And for today's discussion, we're going to focus on general inpatient care, or as we often reference it for short, GIP. And for any of you that are billers, you'll use that revenue code 0656. And again, this is billed as 1 unit equals 1 day on the hospice claim. And again, I'd like to focus or specify that I am not a billing SME or subject matter expert. And so for those of you that would like more information on hospice billing and revenue codes, I've hyperlinked our hospice billing codes job aid at the bottom of this slide. And it says right there, hospice billing codes and level of care revenue codes. And that's a great resource that we have available to you on our NGS Medicare website. So I would suggest checking that out for those of you that are billers. All right, so GIP is definitely a hot topic for providers, and GIP is necessary when your patient is having uncontrolled pain or symptom management that requires an intensity of care that can only be provided in an acute care hospital or SNF. Inpatient type setting. So it's a medical condition that warrants a short-term inpatient stay for pain control or acute or chronic symptom management. Per reports from our medical review department, it's currently one of the top J6 hospice edits. And, for those of you that do look at things like that, so 5C like Charlie, N like Nancy, G like George, X, and 5W, N like Nancy, G like George, X, which are codes for GIP greater than 7 days. Those codes were implemented in 2023, and those are things that they're looking at in TPE review. And also, we do have TPE edit and denial topics that you can also look at out on our website. So when you're considering GIP for your hospice patient, you should also be asking yourselves, what symptoms need to be managed that cannot be feasibly provided in other settings? And again, if you want to check out those TPE topics that are under review, they can be found on our website. Go to our targeted probe and educate review topics, and you can just pop that into our search field under that magnifying glass on the website. All right, and so we previously reviewed that GIP is provided only when the beneficiary requires an intensity of care directed towards pain control and symptom management that cannot be managed in any other setting, right? So what are those symptoms that we're trying to manage that cannot be easily provided in any other setting? Well, here they are on your screen. So, excuse me, things like uncontrolled pain, IV narcotics, which require things like teaching, monitoring, and assessment and reassessment of response to those medications. With your cancer patients, you will see things like pathological fractures, sudden deterioration, and or uncontrolled nausea or vomiting. Those things often require interventions that cannot be provided in a home setting. Respiratory distress, which becomes unmanageable, open lesions requiring frequent skilled care, traction and frequent repositioning requiring more than one staff member, complex wound care requiring complex dressing changes, severe agitated delirium or acute anxiety or depression secondary to the end stage disease process requiring extensive intervention. The key is looking for the symptom changes and then providing skilled intervention and or med administration, and then observation and monitoring, followed by assessment and documentation, which is key. You're documenting those changes, of course, and what will support this as a need for the general inpatient level of care. So documentation should always support the event or intensity of care change that drove the patient to need that GIP level of care. So example, pain crisis, monitored, assessed, and treated with changes in medication regimen. Documentation should reflect every aspect of the medication adjustments, excuse me, interventions and stabilization treatments. As previously stated, when discussing an inpatient respite care episode, documentation collaboration between the inpatient facility and the hospice agency may support the certification of terminal illness. It is suggested that the hospice agency obtain and submit those inpatient facility medical records because, again, a simple note by the hospice nurse that states the patient was admitted to GIP may not be enough to support that GIP level of care. For example, if medication changes occur due to increasing pain upon transport to the inpatient facility or while the patient was admitted during that GIP stay, or if the patient had an exacerbation of the signs or symptoms of their primary diagnosis during the GIP admission, it would be important to include the medical records from the inpatient facility to support the changes in the patient's condition. And examples of documentation to include for the GIP level of care may include things like the ambulance records, inpatient nursing or physician notes, vital signs, INO pain scales, admitting H&P, a discharge summary, frequent evaluations by the MD or nurse at the facility, aggressive symptom management, med administration records, if there were frequent med adjustments, include those, any IVs that can't be administered at home, or complicated technical delivery of medication, such as a PCA or a special IV pump. We don't see a lot of, well, before I get into the explanation, let me read, is this level of care appropriate for this summary? I'll give you guys a chance to look at this for a second, and I'll read through it. So a 72-year-old female with a history of lung cancer with metastasis has elected to discontinue treatments and pursue comfort measures. Wishes to be home. Patient has lost 30 pounds in the past 3 months. She has become increasingly weak per caregiver, receiving IV fluids via right chest wall port. She has become increasingly agitated, rates her pain 10 out of 10, increased from 7 out of 10 1 hour ago during assessment and last PRN pain med administration. Respirations are increased from 20 to 30 breaths per minute. She is diaphoretic and complaining of chest tightening. Adjustments to medications have not been effective at home. Administration record shows changes in medication. All PRN doses have been administered. Patient denies any relief of pain following last PRN pain med. So this is obviously a nurse's note. Is it appropriate for GIP level of care? So we don't see any antiemetics listed, but we could pick this note apart all day, and I think it would still classify appropriate for a GIP level of care. Her pain is not being managed. She has pretty significant change in symptom management that her caregiver will most likely not be able to handle. Now you could call a family meeting and possibly have a social worker come in and discuss options. However, the patient has made it clear that she wants to be comfortable and she is currently not, and that is the priority. So this could most likely be handled quicker and more efficiently in an inpatient setting, as there are more resources available there. So let's talk about potential general inpatient level of care issues. You've got long stays, inappropriate use, not enough discharge planning, documentation isn't supporting it, and the location doesn't determine the level of care. So at the beginning of the presentation, I mentioned that general inpatient care level of care was a hot topic for providers. So I want to revisit a few potential issues that we're seeing, and those are the ones that I've just listed that are on your screen here. Again, GIP greater than 7 days, that denial code is 55H like Henry, 1M like Mary, is still one of the top J6 and JK edits for TPE medical review. So be mindful of your level of care as well as your length of stay. These types of facilities typically are not required to provide skilled care as part of the room and board, and often they don't meet the staffing requirements for a GIP level of care. So make sure you're looking at your IOMs. The Chapter 11, Section 30.1, levels of care data required on an institutional claim. And again, I'm not a billing SME, but I am giving you that reference to be aware of. If you are a biller and you're looking at these things, make sure you're looking at that. That what I just cited, that reference I just cited, Chapter 11, Section 30.1 states payment at the inpatient rate is made when general inpatient care is provided at a Medicare certified hospice facility, hospital, or skilled nursing facility. Therefore, it would not be appropriate to provide a GIP level of care in a non-SNF. However, some nursing facilities are duly certified as a SNF and nursing facility. In this instance, when the Benny requires a GIP level of care and all COPs are met as a SNF, and the SNF is providing these services, the hospice provider could bill for a GIP level of care. So just be mindful. Documentation should be done at a minimum daily, but as frequently as needed or applicable depending on the nature of the crisis or symptomology or event. Quantitative data shows the downward trajectory, which is how we support CTI or certification of terminal illness. And we always want to be supporting that. So discharge planning should be constant and ongoing. We learned that from day one that discharge planning starts at the time of admission. And that's always going to be the way it is. So most or a lot of plans, not just Medicare, don't pay for the day of discharge, and this is not something new. For follow-up questions, specific to this webinar or any educational event, I just want to remind you guys to send those to our shared mailbox, and we're going to talk about, or I'm going to open up the question box in just a second, but I want to make sure that I don't forget. I'm going to put that shared mailbox address right into the chat box now. And I'm typing that as we speak while I'm giving you guys a chance to look at these references. 1 second, and I'll open up that question box. All right, NGS PO at elevancehealth.com is going in the chat box right now. Make sure that, yes, perfect. It went through. All right, opening up that question box there. And here are your references. So your conditions of participation, specifically 42 CFR 418.108, your Chapter 11 and your Chapter 9, of course, and then your NGSMedicare.com, where we've got tons of job aids, webinars, and don't forget about Medicare University, computer-based training, where there's a lot of self-paced learning modules that you can share with your staff. And those are great tools. And just remember, everything we offer in terms of education, job aids, all these events is free. So again, follow-up questions to this event or any suggestions even for education that you want to see that you haven't seen, please send those to that NGSHHHPO at elevancehealth.com. And make sure to reference your PTAN, NPI, and the title and date and time of the educational event that you're referencing when you send in your inquiry. All right, and just a little reminder, we have our podcast. It drops on the second and, oh, well, this says first and third Wednesday of each month, but that's incorrect. So my apologies for that. It's actually the second and fourth Thursday of each month. And again, I apologize for that typo there. But check out our podcast on Spotify and Apple. We just did a new recording this week, and it is scheduled to drop on April 25th. We talked to our appeals department, and that is exciting. We're going to do, or we're going to have an appeals informative podcast, which is going to be great for you guys. We just do a high level overview of the appeals process, and we might even do a part 2 to that because there's much more information that we can provide for you guys. So any suggestions for podcasts, please do send those in as well. This is a great way to get information to our providers in small doses, which we think is really, really cool. It's on the go training too. So, and then just really quick, our social media, connect with us on LinkedIn, YouTube. We have recorded educational videos there for you, and then Medicare Mobile, you can get updates that way. Also, if you're not signed up for email updates, I would suggest that you do that. You can get updates on when we have trainings, what trainings are available, and then obviously our website, NGSMedicare.com, and then also NGS Connects, your free user-friendly way to get claim information and submit your ADRs and a plethora of other resources there. All right, let's look at the question box. We are having hospitals request us to admit patients GIP when they have a patient that is imminent. I think this is to reduce the amount of deaths they have. Is this the right thing to do? Well, I think you already answered your question. Your gut, I would say, if they're asking you to, no. I mean, requesting you to admit a patient for GIP, I mean, you have to do what's right for the patient. uh, I guess everything is a situation, patient by patient, decision. If they're already there, I'm not really sure. I would say, it, and we don't do what if scenarios too, so it's really hard to say. If you had a situation already and there was something going on, I guess I could speak to it. For the date of discharge from GIP, we bill routine care. Should be, the location still be listed as inpatient? Gee, Jennifer, that's a good question. It's more of a billing question, so I could certainly get a follow up on that for you. I want to say, yeah, we, just like I said during the presentation, but yeah, I'm going to follow up with that. If you wouldn't mind, I'm going to remind you, Jennifer, of the NGS HHH PO at elevancehealth.com, and then go ahead and just copy and paste that into your email with today's information for today's webinar and your agency information, because I'll have to send you a solid answer on that once I confer with Krista, our billing subject matter expert. Medicare only is for 5 days of respite. If the family requests additional respite days, can we bill the family for extra days? Yeah, again, billing question, if you wouldn't mind just sending that in, and I will get a solid answer for that. Because with respite, if the family's requesting additional days, respite is only 5. So I'm going to say I would have to check on that for sure. But document. I definitely can tell you that. Make sure you're documenting all of this very thoroughly. All right. Yeah, lots of billing questions. And anyone that does have a billing question, again, please send that in and I will get these questions answered for you. Lots of billing questions today, huh? All right. Can we truly take into consideration time to comfort when using GIP? In our most recent Noridian audit, that was definitely not something taken into consideration. We came out of that audit with the understanding that our bennies could only access GIP if they required an intervention that at no time could be provided in the home. Yeah, I mean, general inpatient care is just that. It's for inpatient. Continuous home care is for needs in the home, for nursing care in the home. And I don't know if that's where the confusion is here. I am getting ready to start my next Lunch and Learn series, and I can certainly spend some time on continuous home care where there's needs for, more intense care in the home, but general inpatient care is for inpatient. I don't know if that helps you at all. Christelle, yeah, they are two different levels of care. And Christelle, if you want to, get more information on continuous home care, we can certainly do that. If you want to send me something following it with, information in the subject line following this webinar, I can certainly provide that for you with the difference between the two. Okay. Yeah, again, we can take this out of, because the webinar is ending, we can maybe talk more via email. All right. Well, I want to thank everyone for joining today. I appreciate your attendance. And again, if you wouldn't mind filling out that survey, that's how we do better to support you. And thank you so much for all the work you do to take care of our hospice patients. Stay safe out there and be well. Bye-bye, everyone.